Good afternoon, everybody. It's been a long time since I've talked to you on the COVID town hall. Unfortunately, our numbers are going back up, and many of the virus variants that we're seeing now are Omicron variants. Now, the Alabama state numbers are a bit skewed because we did not have 5 hospitals reporting this information to the Alabama Department of Public Health dashboard. This information is distributed to many of us in this state so that we can keep up with numbers. So they're going to be underreported, and in time, hopefully, these hospitals will get their numbers in and we'll start having more up-to-date information. So this information that I'm talking about for the Alabama Department of Public Health covers from Sunday to Monday, and then by 4 o'clock every day we get updated numbers. So what they're indicating is that there have been greater than 18,702 new confirmed COVID-19 cases. And again, many of these new cases are underreported also because people are doing home and self-tests which aren't reported. Statewide positivity is 41.1%. Greater than 369 confirmed and suspected COVID patients are in ICUs. 26% of all ICU patients are COVID positive. 45% confirmed COVID-19 patients in ICU are ventilated. And at this point, there are 65% ventilators available. This is a lot different than when we were in the surge about a year ago, when we were, fighting tooth and nail for ventilation coverage. There are confirmed cases of hospitalized flu, as well as hospitalized COVID-19 and flu together. For Alabama, the total deaths since the inception of this disease, or the beginning of this disease in March 2020, has been 7,187. The year 2021, we've noted more than 8,480 cases. For RMC and Stringfellow specifically, total number of admissions for RMC since the inception, or the beginning, March 2020, has been 1,724 or more admissions. And then Stringfellow, remember we had a small window when we had to use COVID for Stringfellow, had 30 admissions. Month to date at RMC, which means January 2022, we've had 45 admissions. Since the inception of the disease and problems here in our area, at RMC we've had a total of 365 deaths reported. At Stringfellow, there were 5 deaths, and that's since the inception. As of today, we've had 2 patients discharged, actually, but totally we have 37 patients in our area. COVID-1, which houses the ICU, as well as more of the critical care patients. We have 19 patients out of 22 rooms present. COVID-2, we have 14 out of 14 beds taken. And in our RMC ER, as of right now, there are 3 patients, unless they've gotten beds. And then in the Stringfellow ER detox, there is 1 patient. So total vents at RMC for COVID, there are 2 on the vent. And our usual MICU, we have 6 patients on vents. And for our COVID ICU patients, remember there were 19 COVID patients in COVID-1. 5 of those are ICU. For our typical MICU, we have 10 patients in the ICU. I just wanted to touch bases on vaccination. So the FDA amended the emergency use authorization for Pfizer and Moderna mRNA vaccines as of January 3rd, 2022. There are 3 revisions. Number 1, and you can read these if you go to the websites. Number 1, to authorize the use of Pfizer BioNTech vaccine as a single booster dose in individuals aged 12 to 15. Number 2 revision was to lower the authorized dosing interval of a COVID-19 vaccine booster dose to at least 5 months after completion of a Pfizer or Moderna series. So to the 12 and older, Pfizer, and then to the 18 and older will be Moderna. And the booster dose after J&J remains at 2 months. The 3rd revision is to authorize a 3rd primary series dose of the Pfizer vaccine administered at least 28 days following the 2-dose regimen of this vaccine in individuals age 5 through 11 years of age who are determined to be moderately to severely immunocompromised. And remember, previously it was authorized to 12 years and older. There are vaccines still available at Tyler. For this week only, Moderna will be given Thursday from 8 until 10 a.m., and Pfizer will be given Friday from 8 until 10. Following this week, starting next week, both Moderna and Pfizer vaccines will only be given on Thursdays from 8 until 10. I just wanted to talk about therapeutic options for outpatient treatment for COVID-19. Dr. Magadia will touch bases on this at length. There are oral treatments. One of them is called Paxlovid, which is provided by Pfizer, and the second one is Molnupiravir, and it's provided by Merck. There are still monoclonal antibodies available, bamlanivimab/etesivimab, provided by Eli Lilly, casirivimab/imdevimab, which is called Regencov or Regeneron, and then sotrovimab, which is provided by GlaxoSmithKline. There is a pre-exposure prophylactic drug called Evusheld, and that's provided by AstraZeneca. And remember, most of these infections are recently from Omicron, and this is something that we see across the country. And there's a question whether BAM and CAS may have limited efficacy, but there are studies looking at that to see how well they'll work. Currently, Alabama Department of Public Health does not carry a supply of sotrovimab, Paxlovid, or Molnupiravir. These treatments are shipped directly to the providers or pharmacies from the manufacturer and allocated to each state based on population or orders placed. There are Walmart stores, I think 39 of them in Alabama, that have product. But there's a process to obtain these, and if you want to go to www.walmart.com/COVID medication, you can read up on what's available and how you might be able to obtain this. And due to limited supplies, treatment should be prioritized to patients that are moderately to severely immunocompromised or at high risk for progression to severe disease, hospitalization, or death. As always, vaccines should be used as your primary preventive course to prevent COVID-19 infection and to protect against the severe disease, to protect against hospitalization and death related to this infection. For more information, you can go to emergency.cdc.gov/lowercase h, lowercase a, lowercase n/2021/lowercase h, lowercase a, lowercase n 00461 period ASP. And remember, WWWV, wear your mask, watch your distance, wash your hands, get vaccinated. And I just wanted to say something about Dr. Hickson. He's a gastroenterologist. He gave me information about how hospitalizations are by vaccine status. And if you look, almost 75%, which is 3/4 of unvaccinated people, are hospitalized. 25% vaccinated, 4% boosted. And that's been something that we've seen across the country that seems to be quite readily appropriate. The vaccine doesn't keep you from getting the disease, but what we've been seeing is the severity of the disease is much less in vaccinated people, especially boosted folks. Again, this is a graph that shows the admission and the deaths by region here. And again, remember, at the inception, we had lower cases found, along with deaths. During December and January of 2021, before the vaccine came about, we had a spike. Remember, both admissions and deaths. The vaccine came about, and we saw a decrease in the number and the decline. And then when the cases increased in August and September of this past year, it was because of the Delta variant, and then now we're seeing a decline and again another rise. So as this virus changes, variants occur, they may become more infectious, more transmissible. So it's always important to please wear your mask, get vaccinated is definitely preventive, and watch out for things. And what we've noted also is that there are labs that aren't doing the Omicron variant testing because it's so readily available or readily infectious and present at this time. So it would overload the labs. Again, the most important thing is to be careful and take care of yourselves. Other than that, I hope, when we have our next town hall that our numbers are less. One thing that Dr. Pappas, who is the infectious disease specialist at UAB, stated was that by the 19th of January, they would probably see a peak in their numbers and then start seeing numbers coming down. And as we watch these numbers, we're not able to say how many patients are admitted to these hospitals. UAB does have the highest, and hopefully by the 19th of this month, we'll start seeing a decline. So please take care of yourselves. This is a new year. We're going on 3 years with this virus, and we want to make sure we stay healthy, productive, and caring. Bye, y'all.
Hi, my name is Whitney Watson, and I'm a nurse practitioner here at RMC. Here at RMC, I serve in several different roles. Currently, I spend most of my time working with Dr. Magadia as part of the infectious disease team, but I also serve in our occupational health and wellness team as part of we run the monoclonal antibody clinic here on campus at RMC, and then we also have a wellness clinic and an occupational health clinic. You may remember me from previous videos, and I'm going to talk today about a few different things. The first thing I want to talk about is monoclonal antibody treatments. We've been hearing a lot about that. And basically what a monoclonal antibody treatment is it's like borrowing soldiers from another. It's like borrowed soldiers to help us fight COVID. So those antibodies come alongside our own immune system and help us to fight COVID. There's been a lot of talk about it, and a lot of people are trying to get monoclonal antibody treatment. Here at RMC, we currently don't have any treatments available with the monoclonal antibodies. You may have heard it as Regeneron, some talking about that, but we do have some ordered, but we are unsure. We have an unsteady supply. So we may get some here and there, but as of right now, we don't have any. Moving from that, I know a lot of people are hanging out at the house with COVID right now. Lots of families I know have been personally touched by COVID and have people out of school and out of work. So I wanted to take just a minute to address how to stay healthy at home with COVID. So one of the most important things that you can do is drink lots of fluids, stay hydrated. When we stay hydrated, it thins the mucus that COVID causes us to have, and that mucus sets up and causes infections like pneumonia. So by staying hydrated, drinking 8 glasses of water, Gatorade, Pedialyte, tea, really any fluid that you can tolerate that you will drink, I am great with you drinking. Another thing that's super helpful is try to spend time laying on your stomach, even if that means putting a movie or game on your phone, laying on your stomach for a couple of hours while you watch it. Sleeping on your stomach if you're able to. I know myself personally, I'm not able to sleep on my stomach. I'm a side sleeper. Sleeping on your side is significantly better than sleeping on your back. So when we sleep on our back for a long time, those secretions that we just talked about, they set up in the back of our lungs here, and they get thick and hard, causing us to form a secondary infection like COVID pneumonia. So sleeping on your back is not great. If you do sleep on your back, I want you to sleep sitting up. Spending time on your stomach is best. If you're not able to, try to spend time on your side each day. It's also important to spend time sitting up, moving around your house, doing your normal dailies of activities and living around your home. Make sure you're taking care of yourself and getting those secretions up. You can also use medications like Tylenol and ibuprofen if you're running a fever. And I know that with COVID comes a lot of body aches, joint pain. If your doctor is okay with you taking those medications, you can use those to lower fever and to reduce the discomfort that you're having. Also, there's plenty of over-the-counter cold medication that's available. Talk to your primary care doctor about some of those medicines that might relieve some of your symptoms. But the big things are stay hydrated, don't lay flat on your back, try to spend time on your stomach or on your side every day. And then if your doctor's okay with it, you can use medications like Tylenol and ibuprofen, or over-the-counter cold medicine can even help ease some of those mild COVID symptoms. Our ER has been very busy lately, and we ask that when you come to our ER, please be patient with us. There is an increased volume of patients because we're having this massive COVID surge. So we want you to please be patient with us and understanding that the wait may be a little bit longer than what you're used to. They see patients in the ER based on who's the sickest first. So just please keep that in mind when you give us a visit. But let's talk about some reasons why you might want to go to the ER for COVID. Definitely do not come to the ER if you're just seeking a COVID test. Reach out to your primary care doctor or the urgent cares in the area. They are able to get you a test, but the ER is not the place for that. That actually increases our patient load and slows us down. If you're able to monitor your oxygen level at home, there's several different ways you can do this. You can buy a pulse oximeter from your local drugstore. I know if you're quarantined at home, that's hard, but DoorDash does deliver from Walgreens and CVS. If you're able to monitor your O2 with an oxygen saturation monitor that slides on your finger, or if you have a newer series Apple Watch, that'll monitor your O2 saturation, as well as there's iPhone and Google Play Store apps that are available, where you hold your phone, you hold your finger over the flash and the camera, and it reads your pulse oximetry reading there, your O2 saturation. So what that number is that kind of gives us an indication of how much oxygen is in your blood. If that number drops below 92 consistently, that would be an appropriate time to reach out to your primary care doctor or to visit us in the ER if it's after hours. Another reason you might want to come to the ER would be if you were unable to keep any fluids down. We certainly don't want people in the community getting dehydrated. So if you're experiencing a lot of nausea and vomiting and diarrhea and you can't keep any fluids down, please come see us in the ER. If you're too weak or sick to get out of bed and get up and get to the bathroom or to get up and make a sandwich, that might be an indication that you need to come to the ER. If you're having significant short of breath, that is if you already have existing lung disease or lung problems and you wear oxygen at home, if you're requiring a significantly larger amount of oxygen, like say if you normally wear 2 liters and now you're requiring 6, or if you're feeling significantly short of breath, or for people without existing lung disease, if you're feeling very short of breath with just your general dailies of activities and living, we want to make sure that you come in and see us in the ER just so you can be evaluated. You may need inpatient treatment. And obviously, if you're caring for someone with COVID-19 and you're not able to wake them up or to arouse them, that's definitely a cause for concern. So please come see us in the ER. I hope that some of these tips helped. We hope here at RMC that you stay happy and healthy, and we're doing our best to support our community during this current surge of the Omicron variant that we're having here in our area. So please reach out to your primary care doctor or visit us in the ER if you meet those requirements. And thank you so much for your time today.
Good afternoon, Dr. Magadia. I'm the infectious disease specialist here at RMC Anniston. Happy New Year to everyone. Here we are again. It's going 2 years. If somebody told me that when the start of pandemic 2 years ago is gonna drag on 2 years, I would tell them that they're crazy, but we are here and we have to move on. So I'm here to talk about 3 topics that had been asked of me recently. The first 2 topics are kind of recent guidelines. The last topic with monoclonal, Whitney earlier kind of touch on that. But the first 2 topics is about the new CDC guidelines on when to stop isolation or quarantine. There's some guidelines that a lot of people had a lot confusion with. This was guidelines that was published 2 days before Christmas, December 23rd. There's also a new therapy for mild to moderate COVID-19 that were given FDA EUA or emergency use authorization right around the same time on the 22nd of December. These are 2 pills that are currently available in limited supply. And the last topic is the monoclonal antibody called sotrovimab for outpatient therapy with people with mild to moderate COVID who might be at risk for progression of illness to severe to the point that they might have to be hospitalized. So that being said, let me deal on the first topic, which is the new CDC guidelines on isolation and quarantine. Just a little bit of semantics. Let me just uh, make some differentiation between isolation and quarantine. So we tell you to quarantine when you get exposed to somebody who have been diagnosed with COVID or tested positive for COVID, but you do not have symptoms yet. So we tell you to quarantine. We tell you to isolate if you got exposed and you have symptoms, or for whatever reason you tested positive. So those are kind of similar things, but they're kind of different. Isolation is when you have symptoms. Quarantine is you don't have symptoms yet. So that being said, CDC kind of made some difference between the two and how to go about stopping isolation. That so, let me just deal with that. So if you are not vaccinated for whatever reason, personal, political, religious reasons, and you have been exposed, but you do not have symptoms yet. So that means you have to quarantine, right? No symptoms, quarantine. Symptoms, isolation. So if you're not vaccinated, CDC recommends that you quarantine for 5 days. So now we're gonna have to go to the rule of 5, 5 and 5. So you quarantine for 5 days. You get off quarantine the next 5 days, but the next 5 days, from day 6 to day 10, you have to wear a properly fitting mask. Probably something that would not have any leakage around it. So for the next 5 days, so that's total of 10 days altogether. If during that time, that you are quarantining, or the time that you're outside the quarantine period, you're wearing masks, you develop symptoms, you have to be tested, and you go back to day one, and the day one actually starts on the day that you tested positive. So let's go on people who are vaccinated. So if you are vaccinated, which is kind of the definition of vaccination kind of changes all the time now that we have, 2 series of vaccination plus booster. So fully vaccinated now means that you have had 2 doses of either Pfizer or Moderna, or 1 dose of J&J plus booster dose of Pfizer Moderna 6 months after those, or 2 months after J&J. So that's what we call vaccinated and boosted, which is kind of technically means fully vaccinated. So if you're fully vaccinated with booster and you get exposed, so there is no quarantine needed if you're asymptomatic, but you have to wear a mask as well, preferably properly fitting mask. So there's a big difference between unvaccinated, 5 days quarantine at home, plus another 5 days of wearing masks, versus vaccinated, no quarantine whatsoever, but they still have to wear masks the whole 10 days. And they have to go back to their, they could start working, go back to work and things like that, as long as they're vaccinated. So now we go to those people who develop symptoms, those people who tested positive, but they're not sick enough to want to go to the emergency room or need to be hospitalized. So regardless of your vaccination status, the rule of 5 applies still, 5 and 5. So if you're vaccinated or not vaccinated, but you do have symptoms, mild to moderate symptoms, fevers, maybe a headache, kind of sniffles, runny nose, not sick enough to warrant hospitalization, you isolate. So remember, quarantine, no symptoms, isolation with symptoms. You isolate for 5 days. If your symptoms are getting better and you're fever free without the need of fever reducing agents like Tylenol, Motrin, and those kind of things, on day 5, day 6, you could get off isolation and go back to work or go back out. But you have to wear for the next 5 days properly fitting mask from day 6 to day 10. During those times that your symptoms get worse, you have to seek medical advice, primary care physician, or their associate, might be tested again or might have some other supplemental medications. So those are the gist of new CDC guidelines for general population. I know it's kind of confusing because of they shorten it from 14 days to 10 days to now 5 days. And the rationale behind that is mostly scientific, because we know now that about 97% of cases in the United States is cases related to Omicron. And we know that Omicron, although it might have increased transmissibility, meaning it's much more contagious, because a lot of people are hacking, coughing, because it stays there in the nose and the mouth. They don't really go down that much to the lungs. So part of the reason why for that is that. A part of the reason for that is the kind of economic structure. So we don't really want to go back to the times that we had in 2020 and 2021. We shut down the economy, and a lot of things associated with the ripple effect on both the medical, economic, physical, social, social and psychological aspects on everybody's life. So, part of the reason for the change is scientific, medical, and part of that is also economic, which I kind of agree, because we know a lot of things now about COVID compared to 2 years ago. So we know that there's the incubation period and all those things. That being said, incubation period kind of changes as well with the original strain. We know that's about 7-8 days. With Delta, it's about 5 to 6 days. With Omicron, it's about 3 to 4 days, maybe 2 days. Incubation period means that from the day that you got exposed to the day that you develop your symptoms, that's those days are the incubation period. All right, so I hope that's kind of clear up the issue about CD guidelines on stopping isolation and quarantine. The second topic that I want to talk about is the new oral therapy available for mild to moderate COVID. And there are two of those, and I'm going to review the data from two major clinical trials. So there's a pill available, made available December 22nd. It was granted EUA by FDA. It's a medicine manufactured by Merck, called molnupiravir, MOLNUPIRAVIR. It comes in 200 milligram tablets, and the dosing is 800 milligrams twice a day for 5 days. And it was granted EUA based on a big clinical trial called Move Out trial, which is a trial that involved about 1,400 patients. So they randomized these two patients to molnupiravir and placebo. They're kind of almost the same, 50% of those who got molnupiravir, 50% of the 1,400 got placebo. And the hospitalization rate after 28 days on people who got molnupiravir is about 6.8%. So of the 709 patients who got molnupiravir, about 48 patients there ended up getting hospitalized, compared to about 9.7% on the placebo arm. About 68 patients out of 699 had to be hospitalized. They also had another parameter that they checked for, which is mortality or death. Of the patients who got molnupiravir, 1 died, unfortunately, whereas in those patients who got placebo, 9 died. So there's a significance, on the molnupiravir arm, it's about 0.1% mortality. On the placebo arm, it's about 1.3% mortality. There's another drug called, and that drug called molnupiravir is available now in limited supply. We called a prescription this morning in one of our patients. We called Walmart Jacksonville, and they do have that drug available for those people who are could prescribe. Primary care physicians, colleagues of ours, and their associates, you could call that into Jacksonville, Walmart in Jacksonville. The second drug is called Paxlovid, which is the brand name for two medication, antiviral medication. One is called nirmatrelvir, and the other one is ritonavir. The first one is the parent drug. The second one is a compound that makes it last longer in the system. We call that cytochrome P450 inducer. So although there are two drugs in that Paxlovid, but there's only one that's really chemically active. So both those two drugs were made available or given EUA by FDA in late December. We called Walmart Jacksonville, and they do not have Paxlovid right now. But anyway, that Paxlovid was given EUA by FDA based on this clinical trial called EPIC-HR, and that involved about 2,200 patients. Again, they randomized two arms, both 50% on the Paxlovid arm. The second arm is placebo arm. And after 28 days, about 8 patients in the Paxlovid arm out of 1,000 patients ended up in the hospital. So that's 0.8%. Compared to the placebo arm, of the 1,000 patients who got placebo, about 66 of them had to be hospitalized. So that's about 6.3% compared to 0.08%. After 28 days, also they measure, one of the parameters that they look for is mortality or death. In the Paxlovid arm, none of them died of the 1,000 patients, so that's 0% mortality. Unfortunately, 12 patients died in the placebo arm of the 1,000 patients, so that's about 1.1% mortality. So they have two different mechanisms of action. For Paxlovid, it inhibits viral replication by inhibiting this enzyme called protease inhibitor. With molnupiravir, it kind of inhibits by causing viral mutation. That being said, molnupiravir is not indicated. It's actually category C for pregnancy because there might be some theoretical issue about mutation. The other one, Paxlovid, is relatively safe for pregnancy, but it's not indicated for it as well because there's no data to support that. The problem with Paxlovid, because it has ritonavir, there might be some drug-drug interaction associated with it. So there's a long list of medications that you might have problems with or might have to consider adjusting the dose based on those drugs, including anticoagulations, cardiac medicines, and things like that. So those are made available now. With Paxlovid, there's only 65,000 courses available compared to about 300,000 courses available for molnupiravir. The Paxlovid is about $530 per course. Molnupiravir is about $700 per course, but it's all free, or there's no cost to patients when a physician or their associate will call that prescription in. So lastly, I want to talk about the monoclonal antibody that Whitney briefly touched on. This new kind of newer monoclonal antibody that we're giving now called sotrovimab. It's made by GlaxoSmithKline or GSK compared to the previous ones that we were giving called bamlanivimab, which is by no, it's not Regeneron, it's Eli Lilly. The other one called casirivimab is by Regeneron or Regencov. Those two ones, the bamlanivimab and the Regeneron medicine casirivimab, we don't give those anymore because they were proven to be not beneficial for the current Omicron strain. So the one that we're giving right now is the sotrovimab because it's been proven to be effective against the Omicron. Unfortunately, though, we've been having issues with supplies, so we currently do not have sotrovimab because of that particular issue. Once we get that, within several hours, because we have a lot of people lining up. But needless to say, it's only available through outpatient. We try to give that for those patients who still have mild to moderate COVID, and they have risk factors for progression to severe to critical COVID. So that being said, and I hope that you have a happy New Year and safe New Year. And there is a question about our census right now. So the question was, with the current wave that we have with Omicron, there's a data out there that suggests that with the previous wave with Delta, majority of patients who will get sick or get hospitalized and eventually get sick, seriously sick, are mostly unvaccinated. We have few who were vaccinated, and there's a question about what's happening with Omicron, and there's some rumors out there that even the vaccinated ones are getting hospitalized or getting sick with Omicron. There's might be some partial truth to that. The start of this wave, we have seen overwhelmingly that the unvaccinated ones are getting sicker. But recently, 2-3 weeks into the Omicron wave, that we're seeing some patients who have been vaccinated who also get sick. But the caveat to that is those patients who are vaccinated who eventually ended up with us in the hospital, they tend to do better. So that means they tend to stay with us less duration of time, meaning they get discharged much quicker. They don't tend to end up in the ICU, on the ventilator and things like that. So we know that there's some vaccinated ones in the hospital right now, but the majority of those vaccinated in the hospital right now have had the 2 doses of Pfizer or Moderna, but they have not had their booster yet. So we know from our personal experience that vaccines still work, and this will allow me to close out my usual advice to everybody how to get out of this pandemic, and we sum it up to 4 letters: WWWV. Wash your hands, wear your mask, watch your distance, and vaccinate. And if you're eligible, please get your booster. Good afternoon. Thank you.